Yeah, I mean, eyes are gross. All right, let's go ahead and continue with viruses. So we finished adenoviruses on Friday. That brings us to herpes viruses. So the herpes viruses are a really broad family of viruses that infect people, well, and other animals too, but of course we're interested in the human herpes viruses. They're enveloped, double-stranded DNA viruses, and they are very well known for establishing latent, recurrent infections. There are some herpes viruses that also do establish transforming or oncogenic infections. They have a lot of proteins that can manipulate the host cell and the immune response. Some of them have their own polymerases, which help promote host cell growth. But at the same time, remember, when we're thinking about how do we fight viral infections, one of the ways that we fight viral infections is by taking advantage of targets they have that are unique. So we sometimes can have antiviral therapies against some of the herpes viruses because they have their own unique targets. Just like any other, or the majority of other DNA viruses, herpes viruses replicate in the nucleus. They can be released through a number of different mechanisms: exocytosis, cell-to-cell lysis, and even through cell-cell bridges. And like I mentioned, they can cause lytic, persistent, latent, and immortalizing infections. They can cause cancer. They are ubiquitous. We find them everywhere. And in order to control herpes viruses, you do have to have a robust cell-mediated immunity. You've got to kill those infected cells. So these are some of the human herpes viruses. We are not going to talk about all of them. We will talk about 5. Herpes simplex 1 and 2, human herpes virus 1, human herpes virus 2, are what you classically think of as oral and genital herpes. Varicella-Zoster is chickenpox. Epstein-Barr is Epstein-Barr, causes mono. And Cytomegalovirus is the last one we'll talk about. Those of you who end up working with patients who might be severely immune compromised, most often through something like HIV progression to AIDS, may see patients who are showing signs and symptoms of Kaposi sarcoma. If you've ever seen the movie Philadelphia with Tom Hanks, he plays a lawyer who has HIV. That has progressed to AIDS in the late 80s, early 90s, and there's a scene where he's in the courtroom, and they're trying to say that they didn't fire him because he had AIDS, which they did. They fired him because he had AIDS. And they're saying, well, we didn't know he had AIDS. We couldn't tell. And he lifts up his shirt, and he has all these lesions all over his body, and that's the Kaposi sarcoma. It's very noticeable. So if you want to watch a movie about what it was like during the early part of the AIDS crisis in the US, Philadelphia is a good one. So again, there are other herpes viruses. We're not going to talk about all of them. But in general, like I mentioned, the herpes viruses are enveloped, double-stranded, DNA-based viruses. This is what they look like via transmission electron microscopy. And sometimes they do exhibit tissue tropism. Certain herpes viruses go to certain types of tissues. For example, the human herpes virus 1 and 2 herpes simplex viruses tend to reside in neurons. Some of the others, like Epstein-Barr, go to immune cells. So it depends on the virus. It may experience some tissue tropism. In general, they'll have early genes that come in right when they infect the host cell for transcription and takeover, additional transcription and production of more enzymes, and then finally the structural proteins will be synthesized. That's pretty standard for most viruses. That's generally what they do. When they get in, they first express the proteins that help them take over the host cell and replicate themselves, and then to help build the structural proteins. What you can sometimes have happen is the genes will be expressed without the virus replicating, and that can lead to what we see in a latent infection. Okay, so herpes. We're going to talk about herpes simplex viruses first. Herpes means to creep. Creepy. And by creepy, we mean they kind of creep out, right? And they can move along the body. There are a lot of proteins that herpes simplex viruses make. 80. That's a lot for a virus. We were talking about viruses with a classmate or a former colleague of mine who's teaching a non-majors introductory class, and somebody was like, I don't know why we have to talk about viruses. Viruses aren't even that important because they're real small. And I'm like, well, tell that to Ebola. Ebola makes 8 proteins, but it also kills you by making you bleed out your eyeballs. So viruses are super important even if they're small. But 80 proteins is a lot for a virus to make. And because of that, many of them are unique. They don't have a human equivalent, so they are good drug targets. And that's why for people who do have oral or genital herpes, they can take drugs to help suppress and prevent outbreaks. It doesn't cure them of the infection, but it does prevent outbreaks, or if there is an outbreak, it can reduce duration and severity of the outbreak. The herpes simplex viruses, both 1 and 2, can infect most human cells. Whether the infection is lytic or latent tends to depend on the cell type. So in neurons, it tends to be a latent infection. That's where the virus will be stored until the next outbreak. And then in like the skin, it can cause lytic infection, which is why you would see the blister formation. Herpes simplex 1 and 2 are very, very similar. They're similar in a lot of ways. A lot of times people will say, oh, one is oral, one is genital. They can both cause infection in both places. So it's not like, oh, well, this one is only oral. It can be transmitted to the genitals. Oh, this one is only genital. It can be transmitted to the oral region as well. They do have some different growth characteristics, and there is some difference in the antigen profile, so you might have a slightly different antibody response. So one isn't necessarily protective against the other. Herpes simplex 2 is more likely to cause viremia, so it can be very dangerous, especially for people who are immune compromised or for newborns. It's very dangerous for newborns to get herpes. So it's, like I mentioned, a lytic infection in most cells, which is why you see like the blister formation in patients who are experiencing an outbreak. But in the neurons, it is latent. So that's where it goes and hides. And what you tend to see is that once a patient has had herpes for the first time, regardless of whether it's oral or genital, it will hide in those local nerves and then come back out basically in that same spot over and over and over again. So we call them cold sores, usually, is what people are talking about when they're talking about oral herpes. If you get cold sores caused by the herpes virus, you probably get them in the same spot, or very, very like similar spot over and over and over again, because it hides in that local neuron and then comes right back out. Yes.
Are all cold sores caused by herpes though, or is that?
Well, I mean, sometimes like you can have, it can look a lot like impetigo, which is like a staph or a strep infection, depending. But if you get that recurrent like blister in the same spot, it's almost certainly herpes, like that recurrent blister. The lysis comes from the virus taking over the host cell to replicate. Because the host cell can no longer replicate, right? It can die, or if the virus bursts out, the host cell dies. So that's when you get the lesion. And then the lesions, the blisters, the fluid of the blisters is full of viral particles. So sometimes you can see under the microscope in infected cells, like if you did a tissue scraping or a tissue biopsy, you can see inclusion bodies where the virus is replicating, or you can see syncytia, those giant multinucleated cells. So again, the lesions will form due to a combination of the viral and the host pathology. So the virus replicating, the virus lysing the host cells, the host immune response, the host cell death, all of that works together to cause the blisters. And then again, these fluid-filled blisters are full of virions. They aren't enveloped viruses. So if they dry out, they can lose their infectivity. So when you have a patient who's got active like fluid-filled blisters, they are contagious. And it's important to have that cell-mediated immune response, that cytotoxic T-cell response to help maintain latency. And you might think, well, I don't want it to be latent, but your choices are, it's either going to be latent or you're always going to have a herpes outbreak. you'd probably choose latent. So the cell-mediated immune response and that strong antiviral inflammatory response from interferon gamma is what helps keep the virus in check, basically, and can help you to not experience outbreaks if you are infected with the virus. Which is also why we tend to see that under conditions of extreme stress or other illness, like a fever, sometimes they'll call them fever blisters because they'll pop out when you have a fever caused by something else. It's because your immune system has been suppressed by something else or is distracted by something else and is not keeping the virus in check. So I think on one of the later slides, it'll be like, oh, stress. It's like, oh, cool, I'm going to go on a first date. Like, I'm really excited, but I'm kind of nervous at the same time, right? Because that's what's going to happen. Because of course it is. So again, it's maintained in the neurons at the site of infection. So for example, they're showing this patient has a cold sore. So the virus will remain latent in the neurons that feed that local area. And that's where, when that patient, or if that patient experiences a lytic infection, that's where they're going to experience it. So here are some of your triggers. Ultraviolet radiation, right? Because that can cause some tissue damage, and that can allow the virus to kind of pop out. Fever, right? Because your immune system is working, there's something going on. Emotional stress, physical stress, like if you actually like physically irritate the area. Menstruation, like the changes in the hormone levels. Foods, spicy foods, acidic foods, food allergies. And then, of course, any immunosuppression, which could be transient or stress-related. Finals week, great, chemotherapy or radiation that suppresses your immune system, or HIV. Okay. So the problem, though, is that latency for you, yes, sucks because, like, oh, now I'm going to get the outbreak again. It means you can get it whenever. But it also provides the potential for lifelong transmission. In general, if a person is not experiencing, let's just say, a cold sore, they're not likely to transmit the virus, like through kissing. It's not impossible, though. And when there is an active lesion, that definitely has the potential for transmission. So, but the envelope does make it sensitive to inactivation. It has to be moist. It can't be dried out. It's sensitive to all of like the disinfectants. So the virus can be transmitted in saliva, vaginal secretions, contact with lesion fluid, mixing and matching of mucous membranes. It can also be transmitted orally and sexually, and by placement into the eyes and breaks in the skin. Now, when we talk about like oral versus genital herpes, herpes simplex 1 is typically associated with oral infection. Herpes simplex 2 is typically associated with genital or sexual infection, but it's not exclusive. They both can cause oral and genital lesions. And what we'll see in just a little bit is that herpes outbreaks are not limited to the oral or genital region either. Breaks in the skin. Right? Keep that in mind. So who's at risk? Children are most often at risk for herpes simplex 1 because everybody wants to kiss the baby. So if you have a baby and your rule is do not kiss the baby, that's a great rule. If somebody tells you, I have a baby and my rule is do not kiss the baby, please do not kiss the baby. Not that complicated. I know they're cute. I know it's hard to resist, but do not kiss the baby. If it is your baby and you're having an active outbreak, do not kiss the baby anywhere. Not on the cheeks, not on the head, not on the lips, nowhere. No kissing the baby. Sexually active people are those that are obviously going to be at risk for the sexually transmitted herpes simplex 2. Anyone who comes into contact with oral and genital secretions could be at risk for infections of the fingers. So if you're going into dentistry and maybe your patient has a cold sore and you touch it, you could get a herpes infection in your finger. Immunocompromised people and neonates are at risk for disseminated life-threatening disease. So again, when we're telling you, like, I know I kind of made a joke about don't kiss the baby. Don't kiss the baby is actually really serious, especially when they're new babies. Because new babies, herpes can be fatal. Older kids, like infants and toddlers, yeah, you're going to give them cold sores for the rest of their lives. But newborns, you might kill them because you kissed the baby. So don't feel bad about telling grandma she can't kiss the baby. More than 90% of people in developing parts of the world have antibodies to herpes simplex 1 by the age of 2. That's how common this is worldwide. Neonates generally can be infected at childbirth or in early childhood. The virus, if you're having an active outbreak or if you're first exposed during pregnancy, can cause infection in utero. And it's estimated that anywhere from 20 to 25% of adults in the US have herpes simplex virus 2, which we typically associate as the sexually transmitted infection. So neonatal herpes simplex, this is why we talk about it. So a neonate who contracted herpes simplex virus during birth, breech presentation, so feet down instead of head down. Right? During childbirth, the head is supposed to be down. Breech means like the feet or the butt are down, not the head. A fetal monitor was placed on the butt because that's the part you can reach. So they went in and put like a monitor on the buttocks of the baby. And because of greatly prolonged labor, the baby was eventually delivered by C-section. The 5-pound boy had minor difficulties that were successfully treated, but on the 6th day, vessels with a red base appeared at the site where the monitor had been placed, so on his butt. Herpes simplex virus was grown from the vesicle fluid and from spinal fluid, cornea, saliva, and blood. The baby basically was close to death. That's what moribund means, with frequent episodes of not breathing and seizures. They treated him with a nucleoside inhibitor. It's to help stop the DNA replication of the virus. So it's a broad inhibitor of DNA replication. The baby also developed bradycardia, so irregular heart rate and vomiting. The vesicles spread to cover the lower extremities, were on the back, palms, nose, and right eyelid. Within 72 hours of treatment, the baby's condition started to improve. Treatment was continued for 11 days, but discontinued because of a low platelet count. So remember, when you're targeting things that replicate really quickly, yes, you're going to target the virus as it's replicating. You may also be targeting cells in the bone marrow, right? Cells of your blood replicate really quickly. So low platelet count means that there's something wrong with the bone marrow. The baby was discharged on the 45th day after his birthday. Normal development was reported at 1 and 2 years of age. So they're implying that there were no long-lasting neurological complications, even though the baby did experience episodes of not breathing and having seizures. At 6 weeks after the birth, so right before the baby went home, a herpes lesion was found on the mother's vulva. But prior to that, there was no lesion. So they didn't know that she was having like an active outbreak or that she had herpes. The baby was successfully treated and was able to overcome the damage caused by the infection. The virus, most likely herpes simplex virus 2, was probably acquired through an abrasion caused by the fetal monitor while the neonate was in the birth canal. That particular nucleoside inhibitor has been replaced with antiviral drugs that are better, less toxic, and easier to administer, things like acyclovir, valacyclovir, famociclovir. So you can see it's 1980, so it's a little bit older. Okay, but I mean, that's a huge risk for that baby. And then these are some other headlines and cases that are a little bit interesting and things that you might have to think about. So in some religious communities, particularly those of the ultra-Orthodox Jewish communities, so a really common thing in Judaism is that boys will be circumcised at about 8 days of age. And that's pretty common. The US is one of the only countries that has a lot of circumcision not related to religion, but that's fine. This is related to religion. In the ultra-Orthodox communities, the way that the wound caused by circumcision is cleaned, you can probably see it right there in that little print, is by the mouth of the rabbi. Yeah, I know. I try not to, I try not to shade people's religion, but that's just like, for me, that's one thing that I'm like, why was that what occurred to you? To clean it with your mouth? Well, if the rabbi has herpes, you have a child, a little boy, baby, with an open wound on his penis, and neonates in this Jewish community in New York City, by the way, were dying of herpes. So they finally did convince the majority of the community to allow the rabbis to not clean the penis with the mouth, and instead to use like a glass pipette to remove the blood from the circumcision. But again, this is one of those, if these patients turn up at your clinic, you can't be like, your religion is not good because you're doing this thing. You have to be very culturally competent, and you have to just inform them that this is a practice that, while it is your deeply held religious belief, it also puts your children at risk. And that's a call you have to make. And so then, what is neonatal herpes? Parents speak of unbearable pain of watching 13-day-old baby die. So it's really, really important in your neonates to keep them safe. So with herpes simplex 1 and 2, again, the more, we talk about cold sores and genital lesions, yeah, okay. But encephalitis, meningitis and encephalitis, especially in your neonates, eye infections, throat, all over. So gladiatorum is when it's on the body, like on a spot on your body that you develop herpes lesions that are not your genitals or your mouth. Whitlow is on the finger. It can also be in the perianal region. So it's not just, an oral or a genital, it can be in other parts of the body as well. So again, cold sores or fever blisters are most common. That's kind of what you see here. This patient has the herpetic whitlow on the finger, but it can cause throat infections, eye infections. The eye infections can lead to blindness. So on the finger, or gladiatorum on the rest of the body. And infections in neonates are often fatal. So direct analysis of the clinical sample can be diagnostic. You can look for those infected cells that have the inclusion bodies or the syncytia. You're looking at fluid-filled blisters, generally located in a specific area. It's not like blisters all over the patient's body. Even if it's like the body form, it might just be on the chest or on the stomach or on the back or wherever that patient was infected the first time. You can look for the presence of viral antigen or DNA. So you can do PCR and sequencing to determine, is it 1 or 2? Nucleoside analogs can prevent or shorten outbreaks. So patients who have been in the past diagnosed with a herpes infection can be prescribed treatments to help them not experience outbreaks anymore, and to make those outbreaks shorter if they do occur. And again, it really, patients who are taking these drugs are at much, much lower risk of transmitting the virus. Washing with soap or whatever can disinfect the virus because, again, it has an envelope. It's pretty environmentally sensitive. And if you are working in a healthcare setting, you'll just wear protective apparel. Right? So if you're a dentist, you don't put your bare fingers in someone's mouth. I don't know why you would have to say that to somebody, but if I have to say it, that means it probably happened at some point. So if your dentist comes at your mouth with their fingers, yeah, get a new dentist. It has to be gloved, only gloves. Okay, questions about herpes simplex viruses. So human herpes viruses 1 and 2. Okay, well, next is 1, 2, 3. Human herpes virus 3, or Varicella-Zoster virus. This is the one that causes chicken pox. So chicken pox is not in chickens, and it's not a pox. It's a herpes. We'll talk about poxes later. The initial infection, chickenpox, the scientific name is varicella. They call it zoster when it recurs and the patient has developed shingles. That's the common name for it. So it's very closely related to the herpes simplex viruses. But again, those of you who have had chickenpox or know anything about chickenpox, you get lesions all over your body instead of localized to a particular area. Also, chickenpox is mostly spread as a respiratory infection instead of a close contact infection. And infection will most often begin in the upper respiratory tract, the tonsils and the respiratory mucosa. So what we're looking at is droplet transmission. Remember, it is sensitive to drying out, so it has to be like good-sized droplets. It's not just like floating around in the air. So droplet transmission, it is pretty contagious. So it would go around classrooms and daycares. If someone brought it home, everybody who was, who hadn't had it before was going to get it. So this one we blame on my brother. He brought it home from daycare, and then my mom was like, "Oh, you're next." Thanks, Mom. And I was next. I made it to the 4th grade before I got it, but I got it. So what happens is it will, and you probably won't experience symptoms at this point as it's kind of replicating and moving throughout the body. And then it will cause a viremia. And so it gets into the bloodstream for the first time. Once it gets into the bloodstream for the first time, it travels to other tissues like your mucous membrane, some of the organs, and it can even get into the skin. And it's in the skin where we usually actually see the major symptoms of chickenpox, which are the lesions that show up in the body. Generally all over the body. They are, from what I remember, very itchy, but not terribly painful. It didn't hurt to have chickenpox. It was itchy. The vesicles, they're not they aren't really usually that big. They're pretty small. I think they do have some fluid in them, and then eventually they dry out like a little scab and fall off. Okay, so again, if you grew up anything like me, my grandma literally put oven mitts on our hands and was like, don't scratch, because my mom had to go to work. So my grandma sat with us I'm like, "Grandma, it itches, too bad. Sorry, kid." She was a nurse. She was really nice, but she was like, "No, you can't scratch because then you'll get scars." And for most kids, that was the major concern. They would scratch and could cause a secondary bacterial infection and then get some scarring. But in some kids, it can be very, very severe. And what we tended to see is that in older children and young adults, the infection was much more severe than in very young children. Most likely because of the robust immune response that older children and young adults have compared to very small children. Shingles will damage neurons. Patients who eventually develop shingles, what we tend to see is that if the patient has had chickenpox, they are at risk for developing shingles because, like a herpes virus, it hides in the neurons. It doesn't hide in all of the neurons. It generally hides in a very particular area, which is unique to each patient. And when it reoccurs along that neuron, and generally only that neuron. But it tends to be very painful because it does cause damage to the neuron. And so my mom, when she gets it, it's on her sciatic nerve on one side. I don't remember which side. And so she always, goes to the doctor and he tells her, "Well, I understand that it's painful, but," and you're like, "Oh my God, what's but?" But he has a patient that gets it on his optic nerve. So she was like, "Yeah, no, I'm fine, thank you." I have a friend whose husband gets it right here along his back, along one of the nerves in the back. It's usually a single spot. Yes.
So can it come and go?
Oh yeah,
So
absolutely.
It will regress, and then a couple of years it could act up again.
Oh yeah, yeah. Generally, we don't see it until our patients are a little bit older, my mom, because my mom's a little bit older. But my first year teaching, I was teaching a micro for nursing class at a community college. I had a student that was 29, but she had lupus, and so she got shingles outbreaks all the time because she had that autoimmune condition. So patients who have autoimmune conditions or have, my friend's husband, he always gets ulcers. He's like stressed out all the time, so I think he half does it to himself. It's like a little bit psychosomatic, but now it happens, and so then he's kind of stuck with it. But so generally what we can do for patients once they reach a certain age is they can be revaccinated. And that re-upping of the immune response can help keep shingles outbreaks down. The problem is that the vaccine is generally not given until patients are 60. So my mom's like, great, now I don't get shingles anymore. I wish I could have had that like 10 years ago. Okay. So there is some passive immunization that can be done after exposure to chickenpox or shingles to help prevent the development of disease, because there is a pretty long incubation period. It's very, very contagious, highly communicable. Like I said, if one kid in the class has chickenpox, every kid in the class that hasn't had chickenpox is going to get it. That's pretty much how it works. And then all those kids will go home and infect everybody at home who hasn't had chickenpox. And so sometimes they used to do like chickenpox parties, where if a family hadn't had chickenpox yet, they would go to where somebody was contagious and try to get everybody infected before they got too old.
My mom did that to me and my neighbor. She sent us to our neighbor down the street who had it, and we're just sitting in her room with her.
Well, she got chicken. Did you get it?
Well, she had, no.
That's good. You're like, oh, thanks, Mom.
Yeah, we're just sitting there like,
Yeah,
here.
this is great. Yeah. So it's estimated that 90% of adults have antibodies against the virus. Of course, these numbers are going to be different now that many patients should be vaccinated. I believe the vaccine was introduced in like 1995, and I got it in 1993. So too bad for me. So you still might have antibodies, but it's not because you had chickenpox. And because you haven't had chickenpox, you're then not at risk for developing shingles. So if you had chickenpox, you're at risk for developing shingles. If you haven't had chickenpox and you've been vaccinated, you shouldn't develop shingles. So shingles will develop in 10 to 20% of patients. So just because you've had chickenpox is not a guarantee that you're going to develop shingles. And 30% of shingles patients will develop basically nerve pain after, where it just persists, like a persistent nerve pain because of nerve damage. Now, we have to be careful with grandma, because if grandma has shingles and baby is not vaccinated yet against chickenpox, if grandma is having a shingles outbreak, the virus is contagious and can infect an unvaccinated person with chickenpox. So luckily, like I said, my mom is now vaccinated. She has not had a shingles outbreak in years. So before my kids were vaccinated, if she'd had a shingles outbreak, it would have just been, well, maybe for a week or two, just stay away from the kids until the lesions go away. She never had any, so we're good. Now the kids are vaccinated, everything's fine. So an unvaccinated person is at risk for chickenpox if they come into contact with shingles virions. So chickenpox was a common disease of childhood. This is what some of the lesions would look like. Some people would get a lot, some people wouldn't get very many at all. I didn't get very many at all. My stinky brother, he got more of them. I think he deserved it, he brought it home. But this is what a shingles outbreak can look like. You see it's like a single horizontal line on the chest. I'm assuming this is a male person, but you never know. But right here underneath the nipple, so along the chest here. With chickenpox, the small vesicles will appear after a 14-day incubation. They will recur and last for 3 to 5 days. They can appear on all surfaces of the body, including the scalp, inside the mouth, the eyelids, the conjunctiva, inside the vagina, like everywhere. When I learned this, I was like, whew, thank goodness I had a very mild case, because everywhere would have been awful. It was bad enough that it itched. But again, the primary infection, like the first time you get chickenpox, is actually more severe in young adults because of that robust immune response that you already have. So if you're going to get chickenpox in general, it's better to get it in childhood, but you shouldn't have to get chickenpox because now you can be vaccinated. So that should be what we do. The CPE, the cytopathic effects, are going to be the same. You're going to see inclusion bodies and syncytia formation. Of course, the symptoms are different. The transmission is different. The antigens are different. The genome is different. So there are ways that you can distinguish it from the herpes simplex viruses. For the most part, there is no treatment. You do not treat a patient that has chickenpox unless they spike a very high fever, because you do get a fever with it, unless the lesions get infected, unless something goes really, really wrong. But the infection with chickenpox itself generally isn't that big of a deal for the majority of patients. Patients who are immune compromised or patients that have shingles, you can prescribe them nucleoside analogs to help them clear the infection. But again, an otherwise healthy child who gets chickenpox doesn't require treatment. The vaccine is available for children 2 years of age or older. There is a stronger vaccine available for those who are above the age of 60 to prevent the onset of shingles. Okay. Questions about the chickenpox? I don't know why they call it chickenpox, because like I said, it isn't a disease of chickens, and it isn't a pox, but that's okay.
If you do get like shingles and you get the vaccine, you can still get the vaccine afterwards?
Yeah.
Does it have like the exact same effect, or is it like you still have some shingles outbreaks?
It should prevent outbreaks. If you get the vaccine and it works and you mount that immune response, you should not have outbreaks anymore. I mean, it's one of those where they can't guarantee you won't have them, but you shouldn't. Or if you do, they shouldn't be as severe. Okay, Epstein-Barr is another common herpes virus that causes infectious mononucleosis, or sometimes they call it mono. Relatively common, especially in teenagers and young adults. It does persist, so you can carry the virus with you forever. It can immortalize B cells. So what we can see in some patients is the development of B cell cancers. It can also cause nasopharyngeal carcinomas. So this is one that can cause cancers, a couple of different kinds, because the receptor for the virus is found on B cells and some epithelial cells of the respiratory tract. So it can only replicate in cells that allow it to replicate. That's pretty normal. What it can do then is cause latent infection of memory B cells. So if you've ever had the infection, you should have some memory B cells that are still infected. It can stimulate and immortalize B cells. We tend to not see that very often in the US. In other parts of the world where people deal with things like malnutrition, lack of access to healthcare, it is more common to see Epstein-Barr related cancers. So the disease results from an inappropriate immune response. So in patients who are generally healthy and get exposed to the virus, we tend to have an overactive immune response, which causes extreme tiredness, swollen lymph nodes, fever, flu-like symptoms. In a situation where patients aren't able to control their immune response, perhaps they have some sort of immune disease, they lack T cells, they have atypical T cells, that's when you can get the development of the cancers. But so in the majority of patients, it's just because your immune response is so good, it's so robust that you feel sick, you don't feel well. It is a lytic virus, but you're not going to experience lesions. And it's often transmitted through saliva, so sometimes they'll call it the kissing disease. But it can be transmitted not just through kissing, but like sharing of food and drinks as well. So don't let your stanky roommate use your cups. I speak from personal experience. My stanky roommate freshman year used my cups. I love her, like we're still friends to this day, but I'm like, fool, you gave me mono. Yeah, sorry, your cups, I didn't have any cups. I'm like, yeah, thanks. You could have cleaned them. She didn't. Gross. Okay. And then she worked at like the Carl's Jr. on campus. I was like, you cannot go to work with mono. Stop trying to go to work. The classic symptom that you'll have patients that have flu-like illness. If you work at any sort of clinic and a young adult turns in that has flu-like illness, what you're looking for is swollen lymph nodes. During mono, they swell up. Okay. You'll also have patients that have a swollen spleen or liver, but most patients aren't like, ooh, my spleen feels a little swollen today. So it's not something that they would notice, but they might notice that their lymph nodes are swollen and tender in their throat. Tiredness and fatigue. I literally have never been so tired in my entire life. Like, I've never been that tired. I'm like, I'm a college freshman. Why am I so tired? I wanted to sleep all day. I had to drop one of my classes because I couldn't get out of bed to go to class. It was awful. And a sore throat. So again, those flu-like symptoms. You're tired, you're achy, you have a sore throat, you might have a fever, but that swelling of the lymph nodes is different. And it's because it's infecting those B cells that are going to the lymph nodes, you're getting the swelling in the lymph nodes. Children generally have a less active immune system, so young children, they tend not to get as severe a disease. But it's your young adults that are going to show up at the clinic with the more extreme symptoms. They can do a blood test for it, and you end up with these, they call them heterophile antibodies. They're just weird antibodies. They have kind of a weird reactive pattern, so you can see that. But generally, if you turn up at the college clinic, they'll go, what are your symptoms? Like, oh, I'm tired, and I'm achy, and I have a fever. And then they'll go like this, and they go, okay, you have mono, bye. And then they send you home. They're like, go take a nap. You'll be fine in a couple of weeks. And you probably will. Okay. So it's estimated that 70% of the US is infected by the age of 30. Doesn't mean that you all experience symptoms, but again, if there's 10 people in a room, 7 of them have probably had mono. And 90% of them will be, she's like looking around like, all right. Even if they didn't know, maybe you got it when you were a kid, you didn't know. You could have been like 5 and you didn't know. 90% will be shedding the virus for life in the saliva. So, when you go on a first date, have you ever had mono? Are you sure? Malaria, genetics, immunodeficiencies, those can be factors that predispose people to developing Epstein-Barr cancer. Epstein-Barr cancer. So this is a boy with a genetic condition called Duncan disease. It's a very significant immune suppression. It leads to some immune suppression. So he had reduced levels of IgA. So remember, your secretory IgA, your mucosal antibody, is going to be important for an infection like this. So he had reduced levels of IgA, a history of thrush, which we haven't talked about yet, but is a Candida albicans infection in the mouth. It's a fungal infection in the mouth, and recurrent episodes of middle ear infections. This member of the Duncan family, the disease is named after their family, had an X-linked recessive progressive combined variable immunodeficiency disease caused by a particular mutation. And basically the B and T cells don't talk anymore. And you know how important it is for B and T cells to talk in order to have a robust immune response. After exposure to Epstein-Barr at the age of 11, he did not develop antibodies to the virus, but general serum levels increased. And they were able to grow Epstein-Barr positive B cell lines from his peripheral blood. Establishment of the B cell lines is indicative of inappropriate T cell control of the virus B cell proliferation. His T cells aren't working, so his infected B cells just keep multiplying because they're not talking to the T cells and saying we have a problem. At the age of 18, he was treated with packed red cells for a lack of red cells. Then 9 weeks later, he developed symptoms of infectious mononucleosis with fever, swollen lymph nodes, tender liver, and swollen spleen. Lymphocytosis, so issues with the white blood cells, predominance of atypical lymphocytes, and a positive mono spot test. So he had mono. Within another 6 months, he was A-gamma globulin. He didn't have any IgG. A-gamma globulin, no IgG. And no detectable B cells. And he had pneumonia caused by both Haemophilus influenza and Mycobacterium tuberculosis. This poor kid, that's messed up. After an additional 5 months, B cells were again detected. The onset of infectious mono at the age of 18 may have resulted from a new infection or a reactivation of the earlier. This case illustrates the unusual nature of Epstein-Barr and other virus infections when the immune response is compromised. So again, the majority of patients are going to show up, if they show up to the health clinic and say, I don't feel well, I'm kind of tired, I think I have a fever. Okay, you've got mono. And you can do a blood test to confirm, of course, but that's going to be your classic presentation. In your patients who are immune compromised, that's where you're going to see some weird stuff. So some patients may develop chronic symptoms, but again, that's pretty rare. But it's a herpes virus. It hangs out forever. So the majority of patients who have ever had Epstein-Barr will continue to have the virus. And again, many of them will shed it for the rest of their lives. It can be diagnosed by symptoms, the irregular appearance and numbers of white blood cells, serology, looking for those weird antibodies, those heterophile antibodies, viral DNA, because it's a DNA-based virus. There is no vaccine, so then, is it best to be infected as a child because the disease is less severe? I mean, if 70% of people in the US are going to be infected, do you want to get infected when you're a kid, when you're a young adult? Pick your poison, I guess. Okay. So we will finish with the herpes viruses on Wednesday. The last herpes virus is Cytomegalovirus. And then I have your exams, so I can pass those back to you.